Shelby, I think we can go ahead and get started.
All righty, welcome everyone. Please take a moment if you haven't already to put your name, state, and organization in the chat. And if you have any questions or need any assistance, feel free to contact Krista at krista.opstedal@minotstateu.edu. Project ECHO is a program that helps share knowledge with local professionals. It connects experts with community practitioners through virtual sessions, making it easier to learn and collaborate. It gives professionals the tools to provide better care and support, especially in rural and underserved areas. This ECHO series is sponsored by the North Dakota Early Hearing Detection and Intervention Program. The purpose of the series is to enhance knowledge of the EHDI system. Our goal is to build state and territory level data and measurement capacity to improve language acquisition outcomes for children who are deaf or hard of hearing. Before we begin, I want to describe an ECHO session and what sets it apart from other trainings. Essentially, ECHO sessions allow us to move information, not people, so it allows you as the participant to actively learn about a topic and ultimately become a resource for your community. We encourage you to ask questions in the chat or unmuting during the Q&A portion of the presentations if you're comfortable. Your participation is key to the success of our ECHO sessions. We aim to create an interactive community where our presenters, stakeholders, and community members all communicate and support each other during the session. We encourage everyone to turn on your camera throughout the session as long as you're comfortable. and we encourage you to be engaged by asking questions and providing feedback. Individual privacy is of utmost importance to us when sharing information. During our case study discussion, please avoid using real names or initials. Please do not identify any individual's family members, friends, coworkers, or email addresses. Your attention to confidentiality helps create a safe and respectful environment for everyone. To receive credit for your attendance today, please fill out the evaluation that will be sent to you after the session. You can earn professional development credits in social work or a certificate of completion for your participation. Now, I would love to introduce our speaker for today, Amy Gaviglio. Amy is a genetic counselor and founder of Kinetics Consulting, LLC, which provides newborn screening, genomics, and rare disease services globally.
Thank you, Shelby. All right. Can you see that okay?
Yep, that looks great.
Okay. So yeah, thank you all so much for inviting me today to talk about a really component of care that is really important to me. And I think part of it is the profession I'm in genetic counseling this is a lot of what we do. And this is how to have difficult conversations and how to acknowledge and understand the potential underlying trauma that individuals are going through, especially individuals who have children with complex needs, and how we can kind of bring this together to provide what is often known as trauma-informed care. So this is my outline for today. And so in the next 25 minutes or so, I will go over various frameworks that have been developed to provide guidance in having difficult conversations. From there, we'll briefly talk about the concept of trauma, specifically as it pertains to medicine and the medical field. And then we'll move on to some general components of providing trauma-informed care. I'm happy to hear that we'll have time for a discussion afterwards, because I do think with this type of discussion and thinking about having difficult conversations, it's a topic that really lends itself to really talking through things and talking through experiences you've had, and even sometimes role playing of how to have these conversations. So I'm glad we'll have some good time for discussion and interaction at the end. But really, before I get started into the lecture piece, I do want to highlight why it's important that we even consider this topic, why it's important to think beyond what we are communicating to consider how we are communicating it. And this slide indicates the results of a couple of relatively recent studies that show that while around 90% of clinician respondents, at least in one survey, felt that delivering bad news or difficult news or high anxiety news was an important skill, only 40% felt they had the appropriate training to do so effectively. And similarly, in another study among physician respondents, only about 30% thought they had learned adequate communication skills, and that this had an impact on their professional satisfaction, not only themselves, but likely their patients as well. And so I think we really need to be focusing more on how we have these conversations. And we see a lot of benefit to having effective communications. We see higher patient satisfaction. We see improved trust in relationships between the patient and provider. We can also see downstream effects like improved adherence to recommendations. And so while it seems like this may may be something that's just, kind of a fluffy topic, we do actually see real downstream effects on health outcomes when we really put time into thinking about how we are communicating results and how we are building the trust and relationship with our patients. So I will start with a review of some frameworks developed for medical professionals in having difficult conversations, just to kind of help us think through the steps that we should be thinking about as we approach patients or families in having some hard conversations. I do think it's helpful for us to consider, though, what we mean when we talk about difficult conversations, and I've already interchangeably used a number of different ways to talk about this. So I think, of course, when we think about this topic, we automatically, I think, focus on providing what we might consider bad or high anxiety news. But difficult conversations with patients and families can really mean a number of different things. And so I think it's helpful to kind of think about all of the spectrum of what a difficult conversation might encompass. So this can include things like disclosing errors in the realm of newborn screening, and in newborn hearing screening. This may be discussing false positive results, which isn't truly an error, but many patients see it that way. It may be assessing the need and readiness for a behavior change. It may be working with patients or families that are angry, that are upset, that have been traumatized by the medical field or society in general. It can be dealing with an elusive or unknown or ambiguous diagnoses, or what we often call the diagnostic odyssey in rare diseases. And so I just want to level set that when we're talking about difficult conversations, while we might be thinking about providing news around a diagnosis, it truly can come into play in a number of different scenarios. So understanding the importance of effectively having difficult conversations in, again, that range of medical scenarios, there are a number of frameworks or models that have been developed for having these conversations. So I've listed 4 of the more common options here, and I'll touch on each one of them in the next few slides. I will preface by saying that as we go through them, you will notice a lot of commonalities between these frameworks, and I'm not necessarily sure that one is truly better than the other, but I think it is more about looking at them and finding the one that resonates with you as a practitioner or clinician or provider. And so I do kind of want to touch on each of them in order to provide you personally with kind of a breadth of options for what might make sense for you personally. So we'll start with the most well-known and probably most well-documented protocol, which is known as the SPIKES protocol. This really has been used quite a bit in the oncology realm, and it's a 6-step process. So it begins with this idea of setting up the conversation. So ensuring that the surroundings are private. If there are other members, family members, friends in the room involving those individuals, sitting down and making the patient feel comfortable. This step also includes things like managing your time constraints and interruptions. So this is really setting the tone and setting the environment for having a tough conversation and being welcoming to what may come. The P stands for perception, and this is the idea of assessing the patient's kind of perception or understanding of the situation. This involves asking things like open-ended questions to understand what the patient or family knows or suspects about what might be going on with themselves or their child. The I stands for invitation. So this is obtaining the patient's invitation to share information. And this can kind of go to this concept of kind of meeting people where they're at and where they're comfortable in the moment. So I think we've all had patients and families who want exceedingly detailed information, as opposed to others who prefer only the basics. And it's really important in this step to respect their preferences at this time. I think sometimes we get so caught up in making sure that we've disclosed everything and provided everything, and sometimes that can actually be do more harm than good if we overwhelm the family. So really understanding where they're at in terms of the amount of information they're capable of taking in the moment. The K stands for knowledge. So this is then the next step of actually sharing the medical facts or information in as much of a straightforward and compassionate manner as possible. So here we're really concerned with things like avoiding medical jargon, being sensitive to the family's emotional state. So providing information in kind of small chunks and maybe checking for understanding, asking what they've heard, asking how they understand what you just said. The E stands for empathy or emotions. And so this is, of course, addressing the patient's emotions with empathetic responses, recognizing, validating their feelings and providing support. I mean, this is really, I think, probably the most crucial step for building that trust and the ongoing rapport that you'll need as you are along with this family in their journey. The S, I think they couldn't decide, so they say it stands for summary and strategy. And so this is, again, summarizing the information provided and discussing the next steps. So this could include things like management or intervention options, follow-up plans, addressing any questions or concerns the patient may have. And so the idea behind using the spikes protocol is just this idea that we help ensure that bad or high anxiety news is delivered in a way that is respectful, clear, and supportive. So I'll go on to the share model. You'll see this is quite similar to the spikes protocol, though I have heard from some clinicians that this seems to resonate a little bit better with them. And I don't know if it's just because it's shorter or what, but you'll see again that this is very similar in approach. So the share model involves, again, setting up the conversation in a supportive environment. Again, ensuring that you're in a private space, a comfortable setting for the discussion. Again, making sure you have enough time, that you won't be interrupted. The H is kind of considering how to deliver the bad news or have the family's perspective. So again, this idea of understanding the family's knowledge and expectations about the situation, asking open-ended questions to gauge their understanding and concerns. The A stands for give additional information. So again, delivering the news clearly and compassionately, using simple language, again, avoiding medical jargon, and again, just providing that information in kind of as small and manageable chunks as possible. R's provide reassurance. So this again gets back to this recognizing and validating the emotions of the family, providing empathy, emotional support. And then again, going to the E, which is empathy, kind of encouraging and validating. So offering support, discussing the next steps, including treatment options and follow-up plans as well. So as you can see, very, very similar. The GREAT framework is a little bit lesser known, but I like to present it because it focuses a bit more on the concept of engagement. And so for some people, this idea around kind of engaging the family resonates a little bit more with them. So again, you're going to see very similar considerations in terms of greeting the patient, knowing the backstory. So again, really setting this idea of not assuming that you know where the family is at, not assuming that you know how they're feeling about the information. And then the R is the rapport. I will definitely, I like some of the language that they use here in particular. So this idea of active listening. Really listening to understand, not listening to respond, really thinking about your body language as well. I think this is an appreciated component of communication, but our body language, especially as practitioners, can often be closed or hurried. And so making sure that you're really having open body language that encourages a discussion and shows that you're really trying to understand where the family is currently at. The E here is, again, evaluation, examination, expectations. So this is going to really be that information dissemination piece, you know, eliciting their knowledge, their goals for their child, their goals for what might happen next, evaluating their emotions, anxiety, setting specific expectations, and then closing with a plan. So they've really wrapped up quite a bit into the E, which is really that essentially knowledge dissemination, kind of checking in on emotions, and then leaving with a plan. They do end with the A, which is acknowledge and address concerns. So here they talk about really asking, what do you still have concerns about from what we've discussed? Trying to address those as directly as possible. Being aware of things like power dynamics and vulnerability. We see this all the time in medicine, especially in underrepresented individuals. So really being aware that you're not inadvertently setting up a power dynamic or making people feel vulnerable just based on your position within the organization or within the medical team. Aligning values and goals, making sure that you're understanding what their values and goals are for the future. And this idea of providing hope. We've heard a lot of this, especially from families that are identified through newborn screening, whether that's blood spot or hearing or heart screening, is that it's really helpful to say, hey, you know, we're screening for a reason because there's something that we can do. You have choices, you have agency, and we're here to kind of help you reach that. And so providing this idea of hope can be really empowering in the moment of kind of difficult conversation dissemination. And then again, leaving with this idea that you're on a journey together, that you know, thank them for their willingness to talk with you, to kind of trust you in this journey, and leaving an open door for ongoing communication and kind of ongoing discussion as the journey and path evolves. So the last one that I will talk about is known as the breaks protocol. And again, this is going to seem pretty redundant, but I think it's important for people to kind of see what's out there and then find the one that makes the most sense to them, that feels the most authentic to you as a provider or clinician. And kind of go from there. So the breaks protocol starts with background. Again, so setting the stage by ensuring, again, that private, comfortable setting. Again, really making sure that you know where the patient is coming from. What are they coming to the table with? Not just the diagnosis or the prognosis or the management or intervention options, but truly where are they coming from, including their socioeconomic, educational status. Who do they have as a support system? Where are those individuals located? Really holistically understanding the patient situation. The R stands for, again, rapport. It is, it can be difficult to know that, you know, sometimes you're the bearer of bad news, and you may be the face that a patient associates with their diagnosis and recovery. And so recognizing that fundamentally important relationship, that you will be part of this family, whether you continue with them or not, this is a big deal. And so just making sure that we approach it with humanity and care. The E is exploring. So again, this is this idea of understanding what the patient already knows, what their expectations are, what their goals are, and then kind of moving from there. So really, again, just kind of understanding where their knowledge base already is, what their family dynamics are, kind of what they expect might be happening from here on out. Announce is setting up the right way to actually announce whatever the news. And again, this really goes back to this idea of mirroring the patient's emotions and proceeding with empathy. K stands for Kindle. So this is confirming that the patient understands what you've told them. So this again can be asking, what did you hear me say? Do you need me to clarify anything? Is there anything that doesn't make sense? Really kind of understand kind of how much has been absorbed in that moment. And I think it's really helpful to think about when we've gotten bad news. I think all of us have probably gotten some bad news at some point or another, and your brain shuts off. You hear very little after you've gotten a diagnosis or after you've heard news. And so appreciating that that's physiologically how we often react to bad news, and taking the time to kind of check in and say, what have you heard? What have you absorbed? What do we need to go over again? And then again, S is this idea of summarizing. So revisiting the main points, making sure everyone's on the same page for a plan to move forward, and then, checking on that kind of final emotional state before you let them go, and asking about what they have for support after they leave the room or the visit. So I know I just threw 4 large models and frameworks at you. Hopefully you saw things that you liked or resonated with, and at least appreciated that in general, there is kind of a clearly recommended flow and steps of having difficult conversations. So now that we have some frameworks or models for delivering bad news, I'd like to dive deeper into understanding why it is so important to utilize these in practice by really considering the role of trauma in the medical system, especially in patients and families who are faced with complex medical and social issues. So what exactly is trauma? So I usually lean on the definition from the Substance Abuse and Mental Health Services Administration, or SAMHSA, and they define trauma as anything or any experiences that cause intense physical and psychological stress reactions. So trauma can refer to a single event, it can refer to multiple events, or a set of circumstances that is experienced by an individual and perceived as physically and emotionally harmful or threatening. And trauma generally has lasting adverse effects on the individual's physical, social, emotional, or spiritual well-being. And we see this concept of trauma arise, especially in children with genetic and or complex conditions. So studies have shown that children with complex conditions are at an increased risk for a wide range of trauma and adverse childhood experience exposures, particularly in relation to the notion of medical trauma. So medical trauma refers to the psychological and physiological response to a negative or traumatic experience, particularly in a medical setting, such as a hospital or doctor's office. So this type of trauma can result from various situations, of course, including things like a severe illness, injury, invasive procedures, or distressing interactions with healthcare providers. And it's important to note, I think especially as we're thinking about pediatrics, that medical trauma can and often does impact both the children and their caregivers, their parents, or their legal guardians. And this is an area we've been doing quite a bit of work on in terms of really trying to better understand the role of trauma in complex conditions and genetic conditions in rare diseases. And we've identified some really unique attributes to these patients and families. So this graphic shows results from some focus groups that we've held with individuals and caretakers. And you can see a number of experiences that can result in trauma in these families. So including things like experiencing the loss of a child or almost losing a child, watching your child endure painful or frequent medical procedures. And this can be either trying to figure out what a diagnosis is, or it could be post-diagnosis in terms of treatment and management. One of the things we hear quite a bit in the rare disease community is this concept of medical gaslighting. And this is when a healthcare provider dismisses or minimizes the health concerns that are being brought up by the family. And what we hear a lot from family members is that it essentially makes them doubt their own reality. Are they actually seeing what they think they're seeing? Are they too hypervigilant? In this really can really be a tough situation for families. Simply navigating complex medical systems and insurance coverage can be very traumatic for these families. The history of genetics and its use, especially in certain populations, comes up pretty often as well. Difficulties with access to care and treatment, especially in diseases or rare diseases where you may have to go across state lines, or you live in an area where you don't have specialty care. And then the last one I'll mention is this idea of guilt and stigma, especially in genetic conditions, and having, quote unquote, kind of passed on a condition to your children can be a hard concept to deal with. And so understanding this, we really need to ask ourselves how we can mitigate or prevent trauma, and how do we take those frameworks and models that we discussed at the beginning and integrate it into kind of a holistic model of care, which brings us to this concept of trauma-informed care. So trauma-informed care is an approach to healthcare that recognizes and responds to the impact of trauma on individuals. So it shifts the focus from asking kind of like, what's wrong with you, to what happened to you. And this approach aims to create a safe and supportive environment for patients by understanding that their past or current experiences affect, in many ways, their current health and behaviors. So the 5 R's of trauma-informed care are principles to guide the healing process and create a supportive environment for individuals who have experienced trauma. So these principles are realize, so understand, realize the widespread impact of trauma and understand the potential paths for recovery for patients. Recognize the signs and symptoms of trauma in people that are going through medical services, their families, or even your own coworkers and colleagues. So really thinking about and recognizing signs and symptoms. There are some screening mechanisms and tools out there that can be used to screen individuals for trauma as well. Definitely happy to talk more about those as well. Respond if you do identify someone who you believe is experiencing trauma, has experienced trauma. Make sure that that idea is integrated into your organization, that you have an idea of what to do next, that you know how to refer for further care and needs of the family. Resist re-traumatization. So this should be pretty self-explanatory. Make sure that you're setting up an environment that mitigates the chance that you re-traumatize any families. And then this idea that relationship is key. And this is going to get back to this idea of building that rapport, building trust, being seen as trustworthy for patients and families. So this schematic suggests how we can begin to implement trauma-informed care, again, with the end goal of fostering safe, stable, and nurturing relationships and building resiliency for the patient and family. So key principles in the implementation of trauma-informed care, which again are going to kind of start to sound a little bit like the frameworks that we talked about, but creating a safe environment. So ensuring that patients and their families feel physically and psychologically safe in your healthcare or in your public health setting. Building trustworthiness and transparency, building and maintaining trust through very transparent decision-making processes with the family. Empowerment, so recognizing and building on the strength and resilience of your patients as well as your own staff. Really, by adopting these principles, healthcare providers can improve patient engagement, adherence, overall health outcomes. So again, this idea that this makes actually a big difference in physical health outcomes as well, while also enhancing really the well-being of the care team as well. I don't want to, forget that what we do as providers can be very difficult as well. And so trauma-informed care goes beyond just the patient and family, but also the staff, and making sure that this idea is really incorporated throughout the organization. And then the last part is having a growth mindset through peer support and collaboration. So this means integrating individuals with shared experiences into the care process to provide support and validation. I think this is something that the EHDI community does beautifully in their peer support networks, promoting shared decision-making and leveling power differences between staff and patients. So I will end with just some tips and tricks if you're thinking about how to better adopt a trauma-informed approach. First of all, it takes some time. It takes time to implement, and there really is no one-size-fits-all approach. So take the time necessary to ensure really a strategic approach that makes sense for the population that you deal with, as well as the setting that you're in. We did develop a workbook that I'm happy to share with the team as well that has you actually go through and asks you some questions about your organization to kind of see where you're at in terms of implementation of trauma-informed care. Identify champions. This is always the case whenever you're implementing anything. Champions within your organization, really at all levels, who can generate interest in trauma-informed care and really sustain that momentum when adopting new organizational practices. We recommend establishing talking points for making the case as well. And these talking points can really lean on this idea that this isn't just about having conversations, but this is actually a care model that can improve health outcomes. Don't forget non-clinical staff, front desk staff, security, anyone who interacts with patients and may play a really large role in welcoming and making patients feel safe, including everyone. And then, of course, buy-in from your senior leadership, because you are going to need their support to participate in trainings, to develop trainings, promote staff well-being as well. So with that, I will end, and I'm really looking forward to talking about how this looks in your environment, experiences you've had, yeah, anything along those lines. So thank you.
Awesome. Thank you so much. That was so great. I see a question in the chat. It says, can parents having received and processed traumatic news about their newborn learn the skills needed to help others, so grandparents, siblings, in managing their own feelings about the bad news?
Yeah, that is such a fantastic question and so relevant to a lot of the work that we do. So yes, they can, but I think it is, for me, it would be important to talk with them about, is that a role they want to take on? Because they're dealing with their own trauma, they're processing their own trauma. And so I would have the conversation to say, what are your family dynamics? Do you feel comfortable disclosing, what's going on with them? And what is your general role in the family? Are you usually someone who is managing emotions? Really kind of trying to understand what that context looks like. And from there, then you can decide what a path forward may be. It may be that you can help the family, you can help the parents have that conversation. You can role play with them. I've role played with patients before who are worried about having conversations. You can do that. Or it may be they say, I want them to do that, but I don't want to be the person to have to manage that. And that is very understandable. So, I think in those cases, it would be either, can I help you find a genetic counselor, someone for them to talk to help manage those emotions? I think it's a great question that doesn't have a straight answer, but that is how I would approach, dissemination and disclosure to family members, generally speaking, is really seeing what their dynamics are and what role they want or do not want to play in dissemination and managing the emotions around that.
And then there's another question. It says one of your model slides mentioned a warning shot. And what does that mean and look like?
So I think I've kind of struggled with that as well. So for me, it's 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 kind of saying, you know, we're here. It's setting the tone that we're going to have a discussion on something that's going to be difficult. It's essentially kind of just saying, here's a like warning, you know, we're going to sit down, we're going to have this conversation, and it may bring up emotions, it may bring up that. It's really kind of just setting a warning of like, hey, I get that what we're about to talk about is maybe going to be uncomfortable. It's not going to be fun. It's not going to be easy, but I get it and I'm here for it. So it's really kind of setting up that conversation, or at least kind of acknowledging that, you know, we're going to be talking about tough things. And I appreciate that that's not going to be exciting, but I'm here for you. So it's kind of setting the tone again, I guess, is how I would think about it.
And I don't see any